Okay, thank you.
Okay, wonderful. Good morning, everyone. I have the pleasure of introducing this morning our current headache medicine fellow, Dr. Ruying Fu. Dr. Fu earned her medical degree, excuse me, from Sun Yat-sen University and completed her residency training at an affiliated hospital of Sun Yat-sen University. And she's been with us since last July. And it's crazy to think that the end of the year is now approaching. Dr. Fu's research interests focus on migraine pathophysiology and precision treatment of headache disorders. And she will be presenting on that this summer at the American Headache Society scientific meeting in Orlando in June. We're very excited about that. And this morning she's going to be talking about acute, preventive, and interventional strategies for migraine.
Thank you for the introduction, Dr. Rastagi. Hi, everyone. I'm Ruying Fu, and I'm headache fellow. It's my great pleasure to be here to have a presentation today. My topic today is about pediatric migraine management. So, migraine is the second leading disabling disorder in the world, and it affecting over 1 billion people worldwide, um, and it's and you can see that it's a female dominant disorder that affecting 1 in 5 women and 1 in 16 men in the U.S. and 1 in 4 homes in U.S. and um, in the pediatric population, it affects 1 in 11 children. That's important for us. Let's see the diagnosis of migraine. We follow the ICHD3 criteria, and at least 5 attacks meeting the following criteria. So for pediatrics migraine, the duration is lasts at least 2 hours, and which is different than the adults requires at least 4 hours, and more than two of the following. Location should be can be unilateral or bilateral, and should be pulsating pain, moderate severe pain intensity, and the pain can be aggravated by uh, um, causing avoidance of routine physical activity, and more than one of the following: nausea or vomiting, and photophobia and phonophobia. The key here is that the kids cannot for the younger kids, they usually cannot verbally describe photophobia and phonophobia. So it's important for us to infer this from their behaviors, such as seeking a dark room or covering their ears. So, and also it's important that the headache cannot attributed to another disorder. And so understanding the pathophysiology is very important for us to understand the new drugs for migraine. So calcitonin generated protein, which is CGRP, is 37 amino acid neuropeptide. It is a member of calcitonin family of peptide, and the clinical evidence suggests that CGRP may play a causal role in migraine. So this is CGRP molecular, and it mm, located in many places, so such as the smooth muscle cell, and the ferritin and the efferentin pan signal, and the glial cells, master cells. And you can see from here oh, sorry, the TG and the TCC and the thalamus and the cortex. It localized very broadly in the migraine pathophysiology, and so it the mechanism in the migraine is that it can cause vasodilation and nociceptor activation and neurogenic inflammation and it also play a role in central sensitization. So, during migraine attack, the plasma CGRP levels significantly increase compared to the control subjects, and interestingly, it returned to normal level after triptan treatment and achieved migraine relief. So so we it it was indicated to be a generator molecule in migraine pathophysiology. So the GPANs and the GPANs and the CGRP monoclonal antibody are the newer drugs for migraine. GPANs are small molecule that target at CGRP receptor. So, and the CGRP monoclonal antibodies target either the CGRP receptor or the CGRP ligand. These are the medications, ubrogepant, atogepant, rimegepant, or Um, so and the these are the monoclonal antibodies for. And let's see the how triptans and detans work. So triptans work on 5-HT1B and 5-HT1D receptors. So it can cause the activation of 1B receptor can cause vasoconstriction, and the ID receptor activation can inhibit CGRP release. And this is triptan was the is the standard treatment for migraine. And the right side is how detents. This is also a new medication which stimulate the 5-HT1F receptor. So detents do not have the effect of vasoconstriction. So, but it can also cause the inhibition of CGRP release. This is how it work for migraine. And let's see the overview of migraine management. So for migraine, we have both preventive treatment and acute treatment. So the preventive treatment is for to reduce the frequency of headache. To reduce the headache days, and the acute treatment to control the pain as we use as needed at the onset of headaches. So these are the mm, these are the medications and the management we have for migraine. So let's see acute treatment first. So this is the guideline uh, mm, made by the AH and the AN and the AHS for acute treatment of migraine in children and adolescents. This guideline was published in Neurology in 2019. So let's see. For the acute treatment, the guideline recommend NSAIDs, ibuprofen, and triptans such as sumatriptan and sumatriptan, naproxen, and zolmitriptan nasal spray. These medications received recommendations with high or moderate confidence in evidence, and the amitriptan and rizatriptan received a recommendation with low confidence. And also they recommend the dopamine antagonists to use as acute treatment. So um, the right side is the dose for these medications. So let's see analgesics first. So acetaminophen, ibuprofen, and naproxen, and aspirin and ketorolac were recommended in the guideline. So acetaminophen is a non-opioid analgesic. So for the pediatric, we use 15 mg per kg and maximum 1000 mg per dose, and we can use every 4 to 6 hours. The side effects include hepatotoxicity, and the data shows that it's inferior to ibuprofen at 2 hours headache recommendation. Or headache free, and the ibuprofen was recommended as the initial option to to reduce the pain, which got the level B evidence, and we use the dose is 7.5 to 10 mg per kilogram, and maximum 400 mg per dose. And we can also use every 6 to 8 hours. And naproxen, um, mm, the dose is 5 to 10 mg per kg, and maximum 500 mg per dose. And we can use every 12 hours. And aspirin is also a size. So the pediatric dose is 10 to 15 mg per kilogram. But remember, this one can only use in adolescents over 16 years due to the concerning of rising gene risk in kids under 16 years. So at this age group is contraindicated. So and the ketorolac, which use usually in the emergency setting, so the dose is zero point 0.5 mg per kilogram. IV or IM, the maximum 30 mg. So all the NSAIDs have shared similar side effects such as GI upset or GI bleeding or renal impairment with chronic use. So for aspirin, also have the side effect of platelet dysfunction. So these are the analgesics recommended in pediatric migraine. And the triptans are the migraine-specific medications. So the in the guideline, it recommended the amitriptyline and the rizatriptan, sumatriptan, and the zolmitriptan for the pediatric migraine management. So these four triptans, they received FDA approved for kids. So rizatriptan can use down to age 6, and other three triptans can use down to age 12. And so so you can also see that sumatriptan have different formulations such as oral tablets and nasal spray and nasal powder and subcu and auto injection, and zometriptan also have nasal spray and the dissolvable tablet, and the rizatriptan can also have the dissolvable tablet. So subcutaneous and the nasal spray routes usually have the shorter Tmax, so they usually work faster than the oral tablets. So and so amitriptyline, so we use 12.5 mg, and rizatriptan we use 5 or 10, have 5 or 10 mg, and the sumatriptan also have different dosage, and so okay, so this is also the fluorotriptan and the neurotriptans are the triptans that has longer half-life. So we can use for recurrent headaches. So these are the selection of triptans that we often based on the clinical scenario to choose which triptan we is better for the patient. So if you I think you are concerned about the side effects. So, amitriptyline, you can use amitriptyline, nortriptyline, and fluorotriptan. These medications have better side effect profile. And if patients they often experience early nausea or vomiting, they cannot hold down the medication. So the zometriptan nasal spray, sumatriptan nasal spray, and the sumatriptan auto injection, and the rizatriptan this integrating tablet. This can be your options. So if patients experience rapidly intensifying headache, so we can use zometriptan and nasal spray and sumatriptan subcutaneous injection. These work faster than other triptans, and if the headache recurrence, then we can use the naratriptan and aratriptan, which has longer half time. So these are the tips of for prescribing triptans. So we the rule of two. So we can Mm, we can recommend the patients take a second dose after 2 hours, and remember no more than two doses in 24 hours, and maximum 2 days per week. And so we also need to warn patients about the potential side effect. The common side effect are tightness of face, neck, and the chest, and also feeling flushed or flu-like symptoms. And the contraindications include history of cardiovascular or cerebral vascular disease, and uncontrolled hypertension, and hemiplegic migraine, or migraine with brainstem aura or prolonged aura. So, mm So, so here is a question: Is combination treatment such as triptans and NSAIDs used together can be more effective? Yeah, the answer is yes. The data shows that which is the Cochrane systemic review. So the data shows that sumatriptan combination with naproxen has the highest rate of reduction of pain relief at 2 hours. It works better than placebo or either one monotherapy. Sumatriptan and the naproxen together also mm, which achieve the recommendation in the guideline. Let's move to the newer medication, Gepant and Ditan. These three Gepant, Rimagepant, Ubrogepant, and Zavegepant. So these are recommended for acute management for migraine. Oh. I'm sorry, I can hear my voice. It's okay now. Rimagepant, mm, so, Remitriptant, we use 75 mg PO at onset of headache, and ubrogepant we have two dosage, 50 and 100 mg is also oral tablet, and zavegepant 10 mg it comes as a nasal spray. So this is good for patients who cannot hold down the medication. So for the Ramagepant and the Ubrogepant and the Zavegepant, all of these can only uh, use once in 24 hours, and the Ramagepant and the Ubrogepant need to be very cautious to not taken with the strong CYP3A4 inhibitors such as ketoconazole, itraconazole, and erythromycin, and the Japan. These are the Japans, and the Deton, uh, such as lasmiditan. This comes 50 and 200 mg, but unfortunately, it's off market currently in USA, so it's not available currently. Looks like it's because of business reason, not because of the concerning of side effect. So with detents, it's recommended to not drive or operate large machinery for 8 hours after taking the medication. When to initiate the GPANs or detents. Per AHS consensus statement, this is for adults, but in some specialized pediatric case, the statement also recommend can start GPANT when if patients have contraindication or inability or unable to tolerate triptans, or they have failed to triptans, then we can consider to start GPANT for these patients. So here is the poll for acute treatment of migraine. So if patients has significant nausea or vomiting, then we can consider to add an emetic medication, or we can consider non-oral drug routes such as the nasal spray and the auto injection and the dissolvable tablet. And um, if patients experience triptan side effect, we can consider the triptans with good side effect profile, as we mentioned before. And if a patient cannot tolerate triptan or they are indicated to triptans, then we can select a different class of medication such as gepant or detents. And if patient achieve incomplete relief or headache recurs, then except the two triptans that has longer half-life, we can also consider the combination of triptan and the NSAIDs. So, and also we can consider to add dopamine antagonist. So if patients or the parents they don't like medications, then we can consider neuromodulation device. And if you are worried about the medication overuse, then we can start migraine prevention. And also we can discuss, and also we need to discuss medication overuse headache uh, in in these patients. Okay, let's move to the preventive treatment. So one to prescribe preventive medications. So if patients experience headaches more than once a week, or if the migraine impairs their function on a regular basis, or if the patient or parents they prefer to have preventive treatment, or if or if the acute medications are ineffective or be or overused or worry about their side effects, then we can start the preventive treatment. So, this is a list of migraine preventive medications for adults. So, we can we can take a look and so we have the oral uh, we have the established efficacy medications, and also have medications have probable efficacy. So we have the oral tablets and the parenteral medications also, and the non-pharmacological logic options. So this is the AHS and the AN guidelines for pediatric patients for migraine preventive treatment. So topiramate and amitriptyline and propranolol and valproate and cyproheptadines. These are the commonly used medications for kids. So we will. So here are the dose and also the commonly side effect, and and we will discuss in the following slides to uh, um, to have more details. And so let's see the tricyclic antidepressant medications. Amitriptyline and nortriptyline are the most commonly used in this class of medication. So usually the low doses do not have effect on mood, and can also be benefit for insomnia. So can help them to sleep better. So, and Currently, it has insufficient evidence to judge independent effective if use amitriptyline alone. And however, few early studies in pediatrics showed benefits. And CHAMP study and Powers 2013 trials at the the trials that that also so for the amitriptyline. So in the Powers 2013 trials, they demonstrated the efficacy of CBT plus amitriptyline, which uh, received level B recommendation. And so for these two medications, we usually start from 10 mg and gradually titrate up to 1 mg per kilogram per day. So the maximum dose for amitriptyline is 75 mg. So we need to be cautious about the prolonged QT if we use dose higher than 1 mg per kilogram per day. So for these kids, we need to do EKG before we use this the higher dose. So the common side effect for amitriptyline includes sedation and dry mouth and constipation and weight gain. And it also carries the black box warning from FDA. So for the suicidal ideation or behavior. So for younger children, amitriptyline have the crush tablet, and for nortriptyline, we also have the liquid formulas. So other antidepressant medications include fluoxetine and duloxetine, venlafaxine. So topiramate is a medication received FDA approved approval to for kids over modern age 12. So it's probably more likely than possible to decrease headache days and migraine attacks. So it received moderate confidence and from and also had four class one studies. And the CHAMP study also have this medication. So we usually start from 25 mg and titrate slowly over 8 to 10 weeks period, up to 2 to 3 mg per kilogram per day. So another common side effects for topiramate, such as decreased appetite. So sometimes we saw kids lose weight from this medication, and they feel the tingling and numbness in their hands and their feet, and also it can cause brain foggy and the real side effects such as kidney stone and glaucoma and metabolic acidosis. So. Uh, So for topiramate, we have the also have the extended release tablet, and for younger kids, we have the crush tabs and sprinkle capsules. So valproic acid. So pediatric studies have shown the efficacy of this medication. We use this the dosage usually range from 250 to 1,000 mg daily, and the common side effects include GI upset, weight gain, and somnolence, and dizziness, and tremor, and and also the teratogenic side effect of this medication. We should also need to be very cautious. Um, And so for younger kids, it has sprinkles and also have extended release formulation. And other anti-epileptic medications such as zonisamide, levetiracetam, and gabapentin, and uh, lacosamide. Propranolol, it it possibly more likely than placebo to achieve more than 50% reduction in headache frequency with low confidence evidence. So we usually start at 10 mg and titrate up to 60 mg per day or 3 mg per kg per day. So and the common side effects include the dizziness, fatigue, and nightmares and mood. So it's contraindicated in asthma patients. And other antihypertensive medications that can also use for migraine preventive prevention are metoprolol and atenolol and verapamil and flunarizine. But flunarizine is not available in USA. So, cyproheptadine is also commonly used medication for kids to prevent migraines, but with poor evidence. However, it's we found it's effective for for many kids, and so it work by antihistamine and serotonergic mechanism for this medication. So it has a very old evidence that from the reports that in pediatrics they date back to 1970s. So we usually start from 2 to 4 mg per day and up to zero point 0.2 to zero point 0.4 mg per kg per day. So usually we use no more than 3 tablets in most kids. So if they use more than 3 tablets, we commonly see side effects such as extremely tired or drowsiness from this medication. So the common side effect includes sedation. So we use at bednight and appetite stimulation. So we saw some kids they can gain weight from cyproheptadine. So this one is a good medication in younger children. So it has liquid formulation. So that's good choice for kids that cannot swallow tablets. Okay, let's see the famous CHAMP trial. So in this trial, it compares the efficacy of amitriptyline, topiramate, and the placebo in migraine prevention. This trial enrolled 361 children aged 8 to 17 with episodic or chronic migraine. So surprisingly, the trial was stopped early for futility. So in this trial, in this study, they found that no significant difference for any primary or secondary outcome. So it means that the placebo do not inferior to the active medication, and the medication, the drugs also has more reported with more associated with more adverse effects. So So, uh, okay, let's see the another trial for Powers 2013 trial, which compares CPT plus amitriptyline and mm, to headache education and amitriptyline in this trial. So they found that among young persons with chronic migraine, the CPT plus amitriptyline works better at reducing headache frequency and migraine-related disability compared to the use of headache education plus amitriptyline. So the CPT plus amitriptyline received level B recommendation by AHA guidelines. So let's see the newer medication CGRP target therapy. So in this table it lists the two gepants, atogepant and ramagepant were recommended in the AHA guideline to use as preventive treatment. Ramagepant was listed in both acute, can use as both acute and preventive treatment for migraines. So, so these are for atogepant, which is the brand name is Qulipta, it can uh, use for both episodic and chronic migraine. And it has different dosage also. And the ramagepant for migraine preventive, we usually use one tablet every other day. So these are the antibody monoclonal antibodies for is for CGRP. So Amowig, the brand name are Amowig, Jovi, Emgality, and Apti. So Amowig we use monthly, and so it has 70 mg and 140 mg two dosage. And Jovi, so we can use both quarterly or monthly. For monthly we use 225, and for quarterly we use 675 mg. So Emgality, it can the loading dose is 240. So so we use the loading dose first and then 120 mg monthly. And for YFT, it's IV infusion medication. So we can use either 100 mg monthly or 300 mg quarterly. So when to initiate CGRP antibodies. So this is the AHS 2021 criteria for adults. Unfortunately, we do not have the guideline for kids to for the CGRP medications. Uh, so, uh, so in this guideline, the general rules failure of two classes of the traditional preventive medications, such as the one we discussed before, topiramate and beta blockers and amitriptyline or vaccine. And um, so here is the update of the 2024 AHS statements, which list the CGRP antibodies and GPANs as the first line options for both episodic and chronic migraines. And so for it do not require to the failure of traditional migraine preventive medication. So this is so. Um, however, in the real world, the insurance still requires the step therapy of fail to class of traditional migraine preventive medications. So the from Manidumab, which is a Jovi, um, just recently received FDA approval for the preventive treatment of episodic migraine, which has the less than 15 days per month headaches. So in pediatric patients, so it goes age down to age 6, and also requires the kilo weight more than 45 kg. So this is the space trial, which demonstrated the reduction of 2.5 migraine days per month, and also 47.2 percent of patients treated with Ajovy achieved over 50% reduction in migraine days, compared to 27 percent with placebo. So this is good news for us. We have the CGRP targeted therapy for kids, for which uh, received the FDA approval. So the safety and the for safety point standpoint for CGRP, it's generally well tolerated, and the injection site reactions are the most commonly reported side effects. And the other side effects such as upper respiratory tract infection, constipations, and back pain and sinusitis. So uh, Emavik was reported to have side effect of blood pressure elevation, and Ajovy and Amigality reported to have sensitivity reactions, and otherwise it's generally well tolerated. So we also have the nutraceuticals as alternative or adjunctive options. So riboflavin and magnesium and coenzyme Q10 are the commonly used for kids. So these are generally that have favorable safety profile, but the and but the evidence how even the evidence is poor, but many clinicians use these medications prior to as first-line treatment prior to medications after the CHOMP study. And usually we recommend give a child of at least 3 months uh, um, to assess to before assessing the efficacy. So riboflavin we use 50 to 200 mg BID. So it can cause the urine. It can turn the urine to yellow-orange color, and magnesium. So we use 9 mg per kilogram per day BID. So the side effects include the common side effects include diarrhea. So we usually use the chelated forms such as magnesium uh, oxidation and magnesium glycinate, which can be better tolerated, and Q10 we use 50 to 100 mg BID. So this is generally tolerated. So these are the natural supplements for options for migrant kids. So for migrants, we also have the interventional procedures. So Botox injection, which is FDA approved for chronic migraine as preventive treatment. So we use 30 gauge syringe and dilation. We for 200 unit tablets, we dilate with 4 milliliter normal saline, and we so we usually ask for patients to sit for the posterior injections and lying down for frontal and temporalis injection. You can also ask them to lie down for all the injections, for the entire injection. So this is the preemptive protocol for Botox injection. So it recommended 31 injection sites and divided to across 7 specific areas in over the head and the neck muscle. So so this from the picture you can see the injection sites on the front, the temporalis and the occipitalis and the cervical pronasal and trapezius. So for the nerve block, we the nerve block usually used as acute and the transitional treatment for acute and chronic migraine. So the figure 1 is the greater and the lesser occipital nerve block, and the figure 2 is the supraorbital and the supratrochlear nerve block, and the figure 3 is the auriculotemporal nerve block. So we usually use bupivacaine and 27 gauge needles and a 3 cc syringe. And for greater occipital nerve, we can for the occipital nerve block, we can use either 3 cc in greater occipital nerve bilaterally, or we can use 2 cc in the greater occipital nerve and 1 cc in the lesser occipital nerve bilaterally. And for the supraorbital and the supratrochlear and auriculotemporal nerves, we usually use 0.5 cc bilaterally. So we also have SPG block. We use sometimes for the status migraine in emergency emergent setting. So the left side shows the spinal planting ganglia. So this is a place we put the medication. So we use lidocaine and Q-tips. So before start the procedure, we need to check for any anatomical variants or abstractions first, and then we insert the lidocaine gel with Q-tips, and the patient and then we ask patients to lie down with the neck extended uh, so then uh, we can catheter placed in nostril and advance to the point of resistance. So we use 1 cc per nostril of 2% lidocaine. So here are the non-pharmacological options for migraine prevention. So the neuromodulation devices, these are the 3 devices that FDA cleared for pediatrics down to age 12 which can use both as can use as both acute and preventive treatment. So the remote electrical neuromodulation, the brain review, and the non-invasive vagus nerve stimulation, gamma core, and the uh, single pulse transcranial magnetic stimulation. So the e-neura. So the review we use most commonly for kids, which and the kids many kids some kids like like this one, but we also see some kids cannot get benefit from it. So these are the another two options. Just cutaneous supraorbital nerve stimulation is safely, and the external combined occipital and the trigeminal neural stimulation with the brand name Relivian can also as options. So, behavioral therapies are also such as biofeedback and the cognitive behavioral therapy and the relaxation training. These achieved grade A evidence. These are effective at all life stages. So, this can be used alone or combined with other medications. So, patient education is also very important for migraine management. So, here are the smart habits. Uh, we recommend to sleep well, and also we screen for insomnia and sleep apnea in the clinical setting, and and the meals and the hydrations. So eat three meals regularly and keep hydrated, and and uh, also exercise at least 3 to 5 days per week, and relaxation are also very helpful. So for kids, we also need to screen for depression and anxiety, and we also the avoidance of triggers are also recommend are also very important. So these are here are the resources for families. So the left side is a headache relief guide, and the right side is American the website of American Migraine Foundation. In this website, there are some uh, um, useful management for migrants. Thank you very much for your attention. So, and here is my email. I'm ready for the questions. Thank you.
That was excellent. Thank you so much for that very uh, good update. And I liked the idea of the sort of the precision medicine. How do you figure out these different devices for different people based on their side effects? So I appreciated that. I have one question for you. You mentioned when you use topiramate, the research shows that above a certain level, you have to be careful about interaction with birth control pills, for example. Is there any thought on dosing of topiramate or valproate as to when you would have to give folic acid supplementation? I know that they say you should use it even for low doses, but is there anything to say that it's dose related, or just if you're on topiramate or valproic acid, you should be on supplementation of folic acid?
Okay, that's a good question. So, for topiramate, if when we use higher than 200 milligram per day, then we should be so it maybe have the interaction with the OCPs. Yeah.
Right, but with folic acid, not sure if it's dose related.
Yeah.
That was a great job. Thank you.
Laura, I think the
Thank you very much.
sorry, I can answer. I think the
Yes.
recommendation is to start folic acid supplementation with topiramate regardless of dose.
Thank
Good to
you,
hear. Thank you.
Dr. Lastagi. So thank you, everyone. We should have a great day ahead. Thank you. Bye.
Thank you, Dr. Fu.